Good morning, guys. So I think I had a chance to meet most of you yesterday, but for those who didn't, I'm Eric Zevallos. One of my main interests is in critical care and ultrasound, and that's why I wanted to give this topic, is because it merges the two. So we're going to talk about flash pulmonary edema first, and I'm going to finish it up by talking a little bit about ultrasound and how it's advancing the diagnosis and treatment of this disease process. I have no conflicts of interest. I'm going to start off by giving you a case, and this is a case I saw back when I was a resident, and it just kind of highlights the typical flash pulmonary edema case. So it was a 60-year-old female who came in with COPD, heart failure, diabetes, was brought in by EMS for acute respiratory distress, been picked up at home. She was complaining of chest pain and shortness of breath, had no fever, no sick contacts. On arrival, she was speaking in about 1 to 2 word sentences, was breathing very quickly. Her only social history was that she did smoke 1 pack per day and had done that for years. When I went to take a look at her, her mentation was very sluggish. She can answer simple questions, but beyond simple questions, there was not a whole lot I could get from her. On her pulmonary exam, she had crackles and rhonchi that basically went all the way up her lung fields. She was using her accessory muscle use, had pursed lips, and was speaking in 1 to 2 word sentences. Now, this was a very obese female. She weighed over 200 pounds, probably well over 200 pounds. And that was really all I had. Heart rate was 130, respiratory rate at 34. Her blood pressure was 210 over 120, and she was satting 88% on a non-rebreather at 100%. And she was afebrile. So this is your standard case. And when I think about flash pulmonary edema, this is the type of patient I talk about. I'm going to spend a little bit of time differentiating this from just your run-of-the-mill cardiogenic patient who has pulmonary edema or your cardiogenic shock patient, because I think the entities are completely different and the pathology behind it are different. So I just want you guys to take a second and think in the back of your head for this specific patient. You don't have to show me hands, but how many of you guys would give aspirin? How many of you would be giving this patient nitroglycerin? How many would be given lasix for this patient on arrival? And who would give morphine? So about 20 years ago, this was probably the standard cocktail you would give for this patient who came in with crackles in their lungs, rhonchi, hypoxic. And we're going to dive through each one of these and talk about them in detail. Now, as far as looking at the literature behind this, it's a very difficult literature search. If you actually spend some time doing it, you'll realize there's not a whole lot of literature on flash pulmonary edema. And it's very confusing because no one categorizes flash pulmonary edema as simply flash pulmonary edema. They start to merge cardiogenic pulmonary edema, cardiogenic shock, all into one entity. And as you guys know, the treatment varies depending on what the pathology is behind it. And so the literature says one thing, but when you use that in practice, it actually causes harm to the patient. In 2007, the AMA described flash pulmonary edema as a highly lethal condition. Mortality rates as high as 15%. Overall, 1-year mortality rate as high as 34%. All right, so very lethal condition. This is a diagram I put together just showing normal blood flow. And this is how I'm going to describe exactly what's happening in flash pulmonary edema. So you have a bad heart to begin with, okay? And that's kind of what triggers all this, is you know you have a bad heart. A lot of these patients go in and out of the hospital for cardiogenic pulmonary edema, but it's not flash pulmonary edema, okay? They come in with normal blood pressure. They're talking, that your typical leg swelling over a couple of days, worsening hypoxia over a couple of days. That's not flash pulmonary edema, okay? Flash pulmonary edema is an acute process where you get a little bit of fluid into the lung for whatever reason, okay? That little bit of fluid in the lung causes your body to feel like it's drowning and stimulates the stress response in your body. So that stress response releases hormones, releases norepinephrine, epinephrine, vasopressin, angiotensin. And what that does is causes vasoconstriction. So you already have a bad heart. Now this bad heart is going to be pumping against an even greater afterload because of all of these hormones. That increased afterload in the acute setting causes more fluid in your lung. And you start to go through this vicious cycle. Okay? What I want you to realize is that it has nothing to do with total body volume. Okay? And that's the biggest point that I want you guys to take home. So a lot of ER physicians call this SCAPE. Okay? Sympathetic induced cardiogenic pulmonary edema. Basically, it is your hormones, your epinephrine, norepinephrine, acutely messing up your overall body. These patients, they're coming in severely hypertensive. So we're not talking about normal tensive patients. We're not talking about your hypotensive patients, different entities. Okay, we're talking about severely hypertensive patients, and you have about 5 to 10 minutes to do something on this patient. Okay, that's why I like these patients. You can make a dramatic difference. These patients come into the ER, knocking on death's door. And in 10 to 20 minutes, you can have them turned around to where they're begging you to go home. Okay? These are the patients that you call the ICU. The second this patient hits the door, ICU comes down and they go, this patient doesn't need to be admitted. They look so good, they can go home, because you can change things around that quickly. If you don't change things around that quickly, these patients inevitably get intubated, gets into the ICU, and have a prolonged stay because of that. So how do you fix it? Well, we already talked about the problem being an afterload problem, right? So it's not a fluid problem, so the treatment's not going to be lasix. It's going to be afterload reduction, all right? And that's the take-home point. To treat this condition, you have to reduce afterload. Before we start talking about afterload reduction, I want to talk about airway intervention, okay? This patient came in speaking one-word sentences, satting 88%. You got to fix that before you start addressing anything else, right? You got to go through your ABCs. So looking at the literature, there's only been 2 main studies that have been done looking at how to fix the airway in cardiogenic pulmonary edema cases. The largest study was done back in 2008, and I want to give you guys a mindset that was behind this study. So there were a bunch of small studies done up to this point. These small studies had shown that NIV decreased mortality, decreased morbidity on patients who received NIV early on in the course with pulmonary edema. So the thought process behind this study was we're going to do a large study, and it's going to prove that by doing NIV early, we're going to decrease mortality, decrease morbidity. That was the mindset behind this study. In reality, what happened is they showed there was no effect on short-term mortality of the study, and this was the biggest study, over 1,000 patients on this one. A lot of questions arose after this study came about because a lot of the ER physicians were seeing something different outside this study in their practice. They were saying, we're seeing decreased ICU stays, we're seeing decreased mortality. So 2 years later, a meta-analysis was done, taking all the studies, but including this 3CPO trial. And they took all the data and basically showed the same thing. It has not been shown to decrease mortality, but what it does been shown to do is decrease overall hospital stay, decrease intubation rates, decrease complications associated with the problem. And it didn't matter whether you were using non-invasive positive pressure ventilation, CPAP, BiPAP. They all had equal benefit. But again, does not decrease overall mortality is what has been shown in these studies. So the take-home point from that is, while it doesn't decrease overall mortality, it's something you should do on every patient that comes in because it buys you time. Okay, so instead of having 5 minutes for this patient to crump, it's going to give you that 30 minutes where you can take the time to reduce afterload. Don't forget, you got to worry about the PEEP in these patients. So just like Rich talked about yesterday, these patients, it is a recruitment issue. Their alveoli are filled with fluid, and the patients are not able to breathe to open up that fluid, those alveoli, the pockets. So you got to start at a high PEEP. Typically, you start at 5. That's going to be too low for these patients. A lot of EM physicians recommend even starting at 10. Some titrate all the way up to 20 in these patients. So you got to start pretty high, titrate up. My general rule is I start at 6 to 8, and then I march up fairly quickly from there. If they're not improving within the first 5 minutes, I'm moving up to the 10, 12, and 14 fairly quickly. So now, talking about afterload a little bit. If you look at the AHA guidelines for the treatment of flash pulmonary edema, they recommend, and again, they blur all this together. So they say any hypertensive patient who has pulmonary edema and aortic insufficiency should receive morphine, nitroglycerin, and diuretics. So specifically looking at nitroglycerin, we know at low doses you get a preload reduction. It's not until you get it to high doses, so above 60 mics per minute, do you start seeing afterload reduction. Based on this, there was a study done in 2007, done out of Detroit by Levy. It's called the Levy study, in which they took this and gave tremendous doses of nitroglycerin on patients' arrival. This was a small study, okay, but this study dramatically changed the way that we treat flash pulmonary edema. 29 patients came in, and they all received extremely high doses of nitroglycerin. The mean was about 6.5 milligrams of nitroglycerin. So every 5 to 10 minutes, they would give 2 milligram boluses of IV nitroglycerin. Okay. On top of that, a lot of these patients received lasix. So the mean dose of lasix was about 80 milligrams. They also received morphine. All right, so these patients received a combination of stuff. But the main endpoint, they were looking at the effects of nitroglycerin. So you can see here, comparing the standard treatment in which you just received your normal dose of sublingual nitroglycerin compared to your high dose, there was dramatic reduction of intubation at 6 hours, the use of NIV, ICU admissions, and total hospital stay. And these are not minor differences. I mean, these are dramatic differences in these outcomes. The big question was, how safe are these high doses? Most people, most hospitals are afraid to go above 40 mics per minute on a nitro drip. I know at our institute, if you have a patient above 40, you cannot go to the floor. You have to go to the ICU. So a lot of people are afraid giving 2,000 micrograms of nitroglycerin at a one-time dose. If you look at this study, though, out of all these patients, when the mean was 6.5 milligrams in that first 10 minutes, only one patient developed hypertension. And that person who developed hypertension, it resolved with a small bolus of fluid. Okay. And again, a lot of these were receiving morphine and lasix on top of these medications. Now again, we're not talking about cardiogenic pulmonary edema, okay? So in your run-of-the-mill heart failure patient, I wouldn't recommend giving that amount of nitroglycerin, but when you have that flash pulmonary edema patient, these doses are safe. So the study limitations for that one study, because again, this study revolutionized the way we treated it. A lot of the way we practice comes from this study. There was no randomization, okay? There was a bias. A lot of these patients were in Detroit, so they were African Americans, had long-standing history of hypertension, multiple medications. It was a small sample size, and it was open-labeled. So there were some downfalls. There have been subsequent studies that have supported the same outcome, though, just using smaller doses of nitroglycerin. There's also been some studies using larger doses. So specifically, one study used 3 milligrams of nitroglycerin, had the same outcomes. Most of the more recent studies have been using 400 micrograms as an initial bolus. And again, there's not a whole lot of studies outside of the levy. They're small, but 400 micrograms and then titrating that down after 5 minutes. And if you listen to things like MRAP or EM-CRIT, Weingart, he's a proponent of this type of method starting at 400. We also have people in our facility who go up to the 2 milligrams right off the front. We see the same outcomes from both. So outside of nitroglycerin, looking at lasix, it's a little bit confusing. So if you do a literature research on lasix, you can see all the way back to 1985, they show poor outcomes with the use of lasix, theoretically. So they show that it will decrease cardiac output, which is the exact opposite of what we're wanting. It will worsen outcomes in the pre-hospital, and it will promote decline of acute pulmonary edema. If you look at these studies, though, there are some pitfalls in each of these studies. So in the first one, looking at the 1985 study, all of these patients had resolution of their symptoms within the next 3.5 hours. So it was not a dramatic outcome of all of these pitfalls. It didn't show to go on beyond those 3.5 hours. They all resolved with a little bit of fluid. Again, it was a small study size, and so a lot of outcomes were made based on this, but it wasn't a truly great literature search. Again, the 1987 one, they said pulmonary edema where they mixed these patients with multiple different types of medications, but after they went back and looked at all these patients, a quarter of them didn't even have pulmonary edema. They had other things like pneumothorax or pneumonia, but a lot of what we were taught comes based on this literature search. And then another study back in the 1990s that looked at just the effects of pulmonary wedge pressure when given lasix. Again, no patient outcomes were really followed through this. They just said that when they gave it, they noticed an increase in pulmonary wedge pressure. How that relates clinically, though, they never really showed. So while lasix in the acute setting theoretically makes sense not to give it, okay, because if you give lasix, if you think about it, flash pulmonary edema, you have an afterload problem. You're not getting blood out of the heart like you should be. So if you start giving lasix, your kidneys are not being perfused well to begin with. Lasix isn't going to work unless your kidneys are being perfused. That's kind of the theory behind lasix not working. Again, these patients are often euvolemic or hypovolemic. So again, you're not trying to reduce total volume. But I will tell you, some of these patients that come in flash pulmonary edema, they do have total volume plus. And so once you treat that initial surge of norepinephrine, epinephrine, hours later, you might have to give lasix. But giving it in the acute setting, I think, is a downfall, just because you got to get those kidneys perfusing before you give a medication that's going to work on those kidneys. Again, no good study to support the way I believe, but there's no great study to support otherwise either. So the take-home point from today, non-invasive inhalation is something you definitely want to do. High-dose nitroglycerin, these are the two cornerstone treatments of flash pulmonary edema. If you do these two things on your patients, you will save their life 90% of the time. Okay, you will prevent intubations, you will decrease ICU stays, and you will decrease hospital stays. Lasix, I'm not an advocate of it up front, but if you do it, I don't think there's enough evidence to say you're wrong in doing it. Okay. Going a little bit of above and beyond, we know that afterload reduction is the key component of this. Adding an ACE inhibitor is something newer that people are starting to talk about, specifically captopril sublingual. Two ways to do this. You can either add it up front when you start giving your nitroglycerin bolus, or you can add it later on when you start to try to wean the nitroglycerin off. Either way is fine. Again, this is just style points because eventually you want to come off of that nitroglycerin. This helps you come off the nitroglycerin. It also adds, once you take your nitroglycerin off, you know it's short acting, so that afterload will rebound within 30 minutes. This helps prevent that as well. And then morphine. When I went through medical school and when I went through residency, people advocated for morphine for basically any kind of pulmonary edema case. The theory was it opens up, it dilates your pulmonary venous system, helps get blood flow through it. If you look at the literature though, if you look at the ADHERE registry, it actually increases ICU stay, worsens pre-hospital patients, increases overall mortality by a dramatic amount, and then increases intubation and basically just overall complications of this disease. So for the most part, morphine has been taken out of the equation now. I don't think very many people continue to use morphine. The theory behind it about opening up venous pulmonary system has been debunked over the last couple of years. So this is what I wanted to go a little bit more into now, is the use of ultrasound in flash pulmonary edema. To understand ultrasound and flash pulmonary edema, though, you have to understand a little bit of basics about ultrasound. So traditionally, you cannot pass through air with the ultrasound machine. That's always been the belief. 15 years ago, you would be laughed at if you said, I'm going to be doing a pulmonary scan looking for pneumonia, effusions, pulmonary edema. Recently, though, 2012, there's been studies showing that bedside ultrasound is actually more sensitive for picking up things like pneumonia, as well as pulmonary edema. The European Society of Heart Failure has actually made a statement last year saying that bedside ultrasound is going to be the future for diagnosing and assessing congestive heart failure in the acute setting. So this is coming, and I think this is one of the best ways to evaluate exactly what's going on with your patient in the acute setting. Looking at chest x-ray versus ultrasound, you can see sensitivities for bedside ultrasound dramatically higher than your standard chest x-ray. Now again, these are with an ultrasound in an experienced person's hands, okay? No one expects for you to learn ultrasound in 2 days and then be able to get these sensitivities right off the bat. But with practice, and it doesn't take a ton of practice, you will get up to about that high. Dramatically better than x-ray, though, is kind of what I want you to take home from that. Two probes that we use for pulmonary ultrasound, we use the high-frequency linear probe when you're looking for superficial structures. So when we talk about ruling out a pneumothorax in the EFAST, you're using this high-frequency probe. When you want to get down into the lung tissue, looking for things like pneumonia, pulmonary edema, you got to use a lower frequency probe so that you can get better penetration into the tissue. Okay? So when you're looking for pulmonary edema, you're going to be using a cardiac probe or your abdominal probe. You just can't get deep enough with the high frequency probe. So this is what normal lung looks like. Okay? Remember, normal lung, you're not seeing lung, you're seeing artifact. So you got rib shadows here, and you have your pleura in between your rib shadows. The ultrasound reflects off of your pleura, and then you don't see anything really below the pleura unless there's something there. So unless you have a pneumonia or you have fluid, you're going to be seeing artifact. So the most common artifact you see is air. This is what air looks like by ultrasound. You get this hyperechoic or bright line and this dirty shadowing underneath the line. Okay? Because, again, you cannot penetrate through that air. So if you had air above your pleura, this is what you would see. You wouldn't be able to see your pleura, you wouldn't be able to see your lung, you wouldn't be able to see your bone, because the ultrasound beam wouldn't be able to pass through that air. When you take that air out, like in a normal lung, this ultrasound beam goes straight down and reflects off of that pleura. Sends it right back up. It sends it at such a high sound wave that it reflects off of your ultrasound probe, and it sends it back down. And you basically get this bouncing effect, which we call reverberation. Okay? And it gives you this artifact that we call A-lines, where you basically get mirror artifact of the pleura. So you get your first pleura line, and then you get the ultrasound sensing the second line, the third line, the fourth line, and it's just a repeat artifact. This is what normal lung looks like, but it's just artifact. Okay? When you see this, you know it's normal though. The other line that you need to know when you're looking about pulmonary edema is what we call comet tails or B lines. Okay? B lines are a specific type of comet tail. There are many, many types of comet tails. B lines are just a specific type. And to diagnose a B line, it's got to start from your pleura. So you see all these lines start from your pleura and it has to come off of the screen. So if it stops halfway your screen, it's not a B line. It's a different type of line. Okay? So these lines completely come off the screen. And this right here is suggestive of pulmonary edema. Okay? So there's an interface occurring between air and fluid in your alveolar septae, interlobular septae, that is causing this artifact. So when you see this in the lung, and if you see it widespread in all of your lungs, that's pulmonary edema. If you see this in an isolated area, so say you're scanning the lungs and you see it in just one area, it's probably not pulmonary edema. It's probably something else like a pneumonia or a cancer or some process that's causing isolated edema. The more of these B lines you have, the higher correlation it has to the amount of fluid that's in your lungs. So if you have 2 or 3 of these lung rockets that go throughout your lungs, probably not a tremendous amount of edema. But when you start getting lots and lots of these lines, that's suggestive of high-grade pulmonary edema. So in flash pulmonary edema, that patient comes in and you scan your lungs, you expect to see this throughout every lung field. So just putting it together, you have an 85-year-old patient or 70-year-old patient that comes in, 85% on room air, and you see this. All right. What's the next question you want to ask after you see that? Okay. So assuming this is everywhere else, what else do you want to know? It's kind of a trick question. It's kind of read my mind. You want to know what the heart's doing. Okay? And it's important because if you see the heart doing this, and I think Rich is going to touch on this a little bit later, you don't have to be a cardiologist to tell me that this is not squeezing well, right? So this is probably secondary to this, cardiogenic pulmonary edema. Okay? On the other hand, if you see a heart that is squeezing well, and you see this, then you got to think about something else that's non-cardiogenic pulmonary edema. Okay? So ARDS, for example. Okay. So going back to what I asked you guys to think about at the beginning, my personal take, I'd give this patient aspirin. I would not give them lasix. Would give them nitroglycerin, would not give them morphine. Okay. Is that basically what most of you guys would have said at first? No? Cool. Any questions? All right. Yes?
When I was in residency, we used to have the nebulizer.
Yes.
Now in my job, it's just that I'm finding remade, and I'm fighting with farmers all the time, and then at the end of I have to do the ball, do it by myself.
Yeah.
What do you think? I mean, the approach to make it. I mean, sometimes I do it and then I put them in the drip, so that doesn't waste. And I have a long discussion. They say the expiration date is only 7 days. That's why they.
Sure.
But I don't know. In residency, we had about the bomb you made.
Yeah, I mean, it's not a hard drip to mix up. Are your nurses giving you pushback as far as mixing it up, or?
No, I do it.
You just do it?
I do it right away.
Yeah. I mean, as long as you're doing it, I mean, that's, as long as they're not giving you a fuss about doing it, I wouldn't, as long as your patients are getting the care they need, I think you're doing the appropriate thing. Usually what we hear about is that nurses have pushback as far as not wanting to give that dose of nitroglycerin. And that's usually where the problem comes in, or hospital policy prevents you from giving that amount, at which case I tell people just do it yourself. If you're already doing it yourself, you've already bypassed all the competition. Yeah. So yeah, the question is, can you do sublingual and make up for it? Absolutely. Here's the problem with sublingual, though, in these patients. So sublingual, you're giving 400 micrograms over a 5-minute period. That's kind of, so at the most, you're giving about 60 milligrams per minute, which is right at that cusp of afterload, preload reduction, right? And a lot of these patients, they're coming in, and that's assuming that they have full absorption once you put it on their tongue. A lot of these patients come in, they're tachypnic, their mouth is stone dry, so they don't get that amount of absorption. So if you're giving one sublingual nitro, you're probably not getting the afterload, you're probably just getting the preload reduction. Now you can give 2 or 3 sublingual nitros, wet the mouth, and that will be just as effective, okay? But you have to realize just giving one sublingual isn't gonna do it. You have to double up or triple up. Yes?
In your presentation about the case, you mentioned the ejection fraction was 30%. So why you are just saying it's afterload vasoconstriction? Here's a pump failure also. Here there's like preload also is there.
Correct. Absolutely.
So why it's like a more biased saying only it is a afterload and vasoconstriction, but not addressing the ejection fraction?
Right, because in this case, the flash pulmonary edema is the acute process. So the pump failure is not a new process. That's probably the underlying reason why the patient went into flash pulmonary edema. But the flash pulmonary edema itself is an afterload problem. It's an acute problem. They still have the pump problem, which you have to deal with later on, which is why I said once you treat that initial afterload, then you got to start considering about giving lasix or treating the actual pump failure part. But in the acute setting, it's not the pump itself that's causing the problem. It's the increase in afterload acutely that's making that pump work a lot harder than it normally does, and you're getting a backup of fluid because of that. So it's definitely multifactorial, but the acute process is the afterload, not the actual pump problem. Because most of these patients live at pump failure. They live a little hypoxic maybe, they can't lay down flat, they have pulmonary edema, but they live at that for years. You know, when they have the flash pulmonary edema, they don't live at a blood pressure of 230 most of the time. So it's the same entity, but this is the acute process and it changes just a little bit as far as the pathology behind it. Beta blockers in the acute setting, no. It actually worsens outcome, increases mortality in the acute setting. What's that? I'm sorry.
Any idea as to what tips the patient?
No, so it probably has to do with the underlying heart failure, but just any kind of stress on the body. So, you know, a little bit of pneumonia can tip them over, a little bit of fluid that builds up in the wrong spot can cause it, medication noncompliance, any little thing that just causes a little bit of fluid to build up into their lung acutely can cause this problem. It's basically any stress that starts to stimulate epinephrine, norepinephrine to release. That's going to be enough to start that vicious cycle. And once you get put on that vicious cycle, there's no turning back unless you have something to stop it in the process. But anything can cause that stress response. Thank you, guys.